So yes, the title of this talk I was given, and it is actually taken directly from a publication earlier this year. There's a slight misnomer though, because wearable technology, you start to think about Apple Watches, etc. But it's actually not to do with that sort of device. And I'll explain why in a moment. So I'm going to quickly talk about a clinical scenario. This was emailed to me this week as I was preparing to come to India. And it was an email referral to me from a district hospital to a tertiary center cardiologist. And the question was, the email title was, can we discharge this patient? The clinical history was a 28-year-old male, presented having had a collapse while getting out of his car. The patient had felt a head rush, but there was nothing about palpitations prior to collapse. And he had a witnessed apparent loss of consciousness for 1 or 2 minutes. He was confused for about 5 or so minutes afterwards. There was apparently no seizure-like activity. There was no previous events such like this, no past medical history of note, no family history of sudden cardiac death. Investigations essentially were all normal. CT head, lab results including troponin, echocardiography, not on any medications. And what they had done was just admit him, telemetry initially, and then 24-hour ECG monitor. They hadn't seen anything, and they were asking me the question, what do we do with this chap now? We're worried about the syncope that he had, and this is his ECG. We're worried about Brugada. Can we discharge him? He was of Asian origin, by the way, so Indian origin. This was, they sent me 2 ECGs. This is one ECG, and this is a second ECG. So I'm not going to say anything more about this case. I just want you to mull over the scenario. I'm going to talk about the title now of the topic. So Brugada syndrome, as we know, the prevalence is actually quite low in Caucasian population, 3 to 5 per 10,000, but about 3 to 5-fold higher in Southeast Asians. Predominant people affected are from Thailand, as you mentioned. It has autosomal dominant inheritance with variable penetrance. And the concern is of susceptibility to ventricular fibrillation and sudden cardiac death at a young age without any structural heart disease or any other associated abnormalities. An annual risk of just above 1% has been reported. There are many, many mutations, but they all associated with loss of function of SCN5A. And that is inactivation, that causes inactivation of sodium channels. And that's reported in about 20% of Brugada syndrome patients. It's worth remembering that the vast majority of patients are asymptomatic. They don't know they have any changes. And many patients, of course, are diagnosed only after fatal events or near fatal events. This is a very, very nice schematic that was published earlier this year by Andrew Cran from Canada. And I've put it up just because it's so beautifully presented. It goes through the whole clinical approach. So evaluation, of course, a detailed history, family history, pedigree, ECG, whereby you should be including 12 lead, and of course the high right precordial leads in intercostal space 2 to 4 ideally. And you should be looking ideally for type 1 changes, so concave. You may remember in 2016 the guidance on this had changed to say that only really type 1 should classify Brugada syndrome, and type 2 and type 3, etc., are not so important, but still give a suspicion in terms of this could still be a problem. Don't forget that actually when you're trying to establish ECG changes, they're often not there at rest, and there is a transient phenomenon about it. So we should be thinking at very early stages of suspicion of using sodium channel blocker challenges, such as procainamide or agmaline, depending on what drugs you have available. But they are very, very effective in those who may have underlying Brugada, as you can see from that schema there. Risk stratification, basically, unfortunately, there's not much. It's cardiac arrest, it's spontaneous type 1 ECG changes, or syncope. You'll note that there's no imaging modality here because there's been no real imaging that has shown anything specific for Brugada per se. Other markers, age, male, EP study may be helpful. And treatment really is also pretty lean in terms of what's available. You need to be able to tell patients that to avoid fever and treat aggressively with antipyretics, because fever can unmask type 1 type of ECG changes and give potential cause for concern for arrhythmias. Pharmacological, well, really, quinidine is probably the only one that has any real data. And in fact, that data, to be honest, is very much in those who have ICD therapy already and continue to get shocks or antitachycardic pacing. And then interventional, it's predominantly ICD, but we're all aware of certain groups who have advocacy for ablation, particularly in the right ventricular sort of outflow tract area. And so the problem, as I've alluded to, is that the resting 12-lead ECG is not particularly sensitive to diagnose because there are transient phenomena. And so taking one ECG will not exclude. You need to do repeated or think about ambulatory monitoring at the very least. And this is 2 ECGs from the same patient at different time points, with the area that is enlarged showing you the very clear V2 phenomenon of ECG changes that you see with Brugada. So now let's go on to what this paper, which I'll show in a moment, was trying to do. Firstly, it's worth remembering that there's all these terms that are now used: artificial intelligence, machine learning, deep learning. And it's worthwhile just having a look at this image, because what it tells you is that artificial intelligence actually encompasses subsets that have machine learning and deep learning. And deep learning is what we see used a lot in medicine. And deep learning is attractive in medicine because it's able to do some predictive analysis and also use image recognition, which is, as you know, seen a lot in the CT MRI world, where they're trying to predict potential LV function, for example. So machine learning, it's worth remembering, actually incorporates basic statistical methods. And this term neural networks is essentially fancy linear regression, just done multiple times with various permutations to try and get things that are not available to us if we did it as humans with standard sort of calculations. And then convolutional neural networks, which is a step further, and this is quite hard to explain, but essentially allows computers to see like humans in terms of visual recognition of objects and also patterns. So it's worth remembering those what's the best word, the overlaps between all these terms and where some of these terms are used correctly or incorrectly. Very briefly, I just wanted to tell you about this. So there are several types of machine learning, but in essence, in medicine, what we tend to do is to focus on the first, that is the top panel, supervised learning, otherwise known as deep learning, where the example shown in this image is actually that of the work you may have seen by the Mayo Group, where they're trying to predict AF from sinus rhythm ECGs, or potential AF in the future. And what they do is they use labeled data, where you know what the ground truth is, and they put it into an algorithm to try and understand whether it can predict correctly if you give them a target data to analyze. But the whole point of it is that it will make errors initially. You need a fair amount of data, and you need to feed back to the algorithm to enhance it continually until you get to a point where you get excellent sensitivity specificity. And that's the whole point of supervised learning. Unsupervised learning is when you have no real feedback, you have no labels, you just have a huge amount of data, and you ask the computer, and I'm talking huge amounts of data, thousands, millions of potential data inputs, and you ask the computer to find hidden structures that we would have no chance of finding. But that's not so relevant, I would say, in general AI applications in medicine. And there's one last one that's just worth talking about, which is reinforcement learning, which actually is based on principles and models of psychological modeling, including things like gaming, where there is a decision process, a reward system, and by that, a learnt series of actions which the computer can then use to try and predict outcomes. The whole point of that was to just give some insight into this next study, which is actually a really elegant study by the group in Toronto. So they essentially, and this was published in JACC earlier this year, just a few months ago. So their whole objective was to try and develop a deep learning model to automatically be able to classify Brugada type 1. And they then applied that model to 24-hour, 12-lead halters because of the temporal nature of ECG changes in Brugada to see if they could detect type 1 pattern. And they included 3 cohorts of patients in their whole data set. Definite Brugada syndrome, in whom spontaneous or drug provocation type 1 was confirmed, suspected, and a healthy control, and a significant healthy control at that. So what did they do? They essentially used 3 different areas of ECG. So 12-lead ECG from about 90 patients comprising definite or suspected Brugada, which comprised just over 1,000 leads of V1, V2, and the high chest leads. They then also took 12-lead halters from 10 patients with 380 leads and took random 10-second selections from those halters. And they also had a very large number of normal controls of nearly 7,000 patients, which gave them about 14,000 leads. So you can see the numbers are small, and that's because Brugada is not that prevalent a disease. So they used that as the training data set for the AI algorithm. They then tested it on 12-lead ECGs of about 40 patients who had a potential chance of having Brugada, 12 of which who definitely did, and 27 had suspected. And then they also did the same for 12-lead halter, again, randomly selected 10-second ECGs from around about 80 to 90 patients. They then, the final bit was after all of that, they deployed it in 12-lead halters to see what results came. So this is actually a nice diagram of what the results showed. So as I mentioned, these were the training and testing cohorts. There's nothing to say really here. This is when they started to, that middle panel is when they started to use the training cohort and put it to the test in the testing cohort. And you can see there that the AUC from the receiver operating characteristic is very high. It's 0.97 on 12-lead ECG and 0.97 on Holter. That's from a relatively modest training cohort. And actually, what they found was they actually looked at how this correlated with cardiologists who had a EP background, who should have a reasonably good identification of Brugada. And actually, they found it was comparable, if not better, than the cardiologists, which is actually really quite interesting. So when they then put that testing cohort algorithm, so it finished then, and actually put it to deployment, what they found from Brugada type 1 patients in 24-hour 12-lead halters, that they were able to detect 86% of those with definite confirmed Brugada, and 48% with induced type 1, and 34% with suspected Brugada. Remember, this is without any sodium challenge. This is just from ECGs from 12-lead, or actually this is from the 12-lead Holter, not just standard 12-lead. So in summary, what they showed was that a model could be developed with relatively modest amounts of ECG data from 12-lead ECG and 12-lead Holters to actually give a very high accurate diagnosis of type 1. And that is actually quite important, and that's even without any fancy sodium channel blocker challenging, which again, many hospitals will not be comfortable doing unless there's a specialist on site. So hold that thought now. I'm going to show you one other study that's actually very interesting and just cover it in a very short amount of time. This was published earlier this year again by colleagues in Asia. And essentially what they started out saying is that we know that deep learning models can potentially work. We've seen it in sinus rhythm to predict AF. Can it work in Brugada? But they've taken a slightly different approach this time, which is quite novel. They've said, we know that Brugada ECGs are not hugely available. So how are we going to train our model if we don't have a huge amount of data set, albeit we've seen it can be possible? So what they said was, okay, well, what is close to Brugada? It's right bundle branch block. And we've got loads of right bundle branch block ECGs in our database. So why don't we train our algorithm first step to identify right bundle branch block? So they used that, and then as the second step, transferred that algorithmic knowledge of right bundle branch block, and then refined it further for the Brugada population. So that's called transfer learning in this particular deep learning model. This is their schema of the number of ECGs that they used. So it's worth looking at, because essentially the initial step from right bundle branch block, they had just over 2,000 ECGs with confirmed right bundle, and a similar number of ECGs without right bundle. And that's how they trained the initial first step. They then transferred that learning to actual Brugada and equivalent number of non-Brugada ECGs. Very modest number, right? 276. But that's probably the sort of number that we'd have in our hospitals, if not less. And then they sought to see what sort of AUC curves that they were going to get. And they, again, compared with cardiologists who had an interest in Brugada. And what they found was, and this was just that initial AUC curve, but what they found was that the deep learning model was actually very good, similar to our previous study. We've got an AUC of 0.96. If you look at what the cardiologists were able to do, it was 0.81. So significantly better than fairly well-trained cardiologists in identifying with this particular transfer learning method of diagnosing Brugada type 1. So the study findings are essentially that if you can use this other method of transfer learning, you can also get very highly accurate diagnosis of type 1 with very, very robust AUC numbers. And it was better than specially trained cardiologists at diagnosing. So let's put this all together. This is early days, but clearly we are seeing that if you use techniques sensibly in terms of deep learning or artificial intelligence, whatever you want to call it, you can potentially come up with a diagnostic algorithm that is better than cardiologists. And because it is a machine that's doing this, you can then think about screening potentially if you've got a population at risk. You can do so much earlier than before. You can do so before even thinking about provocation challenges. You can reduce that workload of, is this Brugada? Can we do something with this patient? And avoid also, importantly, inappropriate diagnosis, because I think there's a lot of that patients are labeled with possible Brugada and they go around with this cloud over their head for several months or years. And the Toronto group study, I think, is very important because it shows that because some ECG features are transient, you can even apply this to wearable Holter monitors with automated deep learning waveform analysis to also help to screen. So this sort of technology may be scalable to population-based screening if there is a concern about inherited arrhythmic disorders, in particular those who have transient ECG features. So just going back to my clinical history, my case of the young 28-year-old male with essentially a right bundle branch block who was Asian in origin and had a syncope without clear palpitations being a part of the equation. What would you normally do in this circumstance, in this situation?